board.
Hi, everybody. I'm Lisa Ebert. I am a nurse at Aspirus Wausau Hospital. I work in the emergency department as well as I'm the stroke coordinator for our system, which is made up of 10 hospitals. So today I am here to talk to you about what life in the emergency department is like. So I'd like to know a little bit about each of you as we get started. All right. Let's see, Jordan, do you want to start?
Sure. Hi, I'm Jordan. I'm from Milwaukee, and I'm going to be a junior next year. I've been doing Ready Camp for I think 3 or 4 years now. Yeah.
Great. All right, Janice? Oh, you must be muted, Janice.
Sorry. Hi, my name is Janice. I'm a rising sophomore from Detroit, Michigan, and this is my first year at Ready Camp, and I'm also part of the FEMA Regional Youth Preparedness Council.
Great, thanks. And Damien?
Hi, my name is Damien Wisher. I'm from Milwaukee. I am, this September, I'm going to be in 6th grade.
All right. Hi, Damien. Anyone else on that I can't see? All right. Well, this is meant to be very informal. So as you have questions, please feel free to ask them as we go along. If I can get my slides to advance here. All right, so this is where I'm hoping it to be kind of interactive, and we just talk about who works in the emergency department. What kind of people do you think work there? Like, what kind of jobs are there in the emergency department?
Like nurses, doctors, surgeons, physicians.
Okay. Anyone else? Those are the most common that people think of when working in the emergency department. So we're going to talk about who works there and what type of training that they may need as we go along. So this is a list that I came up with of all the different type of people that I work with in the emergency department. So as you said, Janice, doctors, nurses. We have a whole team of physician's assistants or nurse practitioners. So they're advanced practice providers. They maybe have a background in either one. Paramedics and EMTs, pharmacists, and each emergency department kind of has a little bit different makeup. We have our own pharmacist in the emergency department for 12 hours a day. We have clerks. Now the clerks are kind of like our, they keep things running. So they're the ones that are answering the phones, paging people, keeping track of different things, and a very important role in what they bring in. Clerks, most of what their training is on-the-job training. So they come here, we teach them about our electronic medical record, we teach them about the different types of patients that they're going to be seeing, we teach them all of our protocols, and we have, at some points during the day, we have 3 different clerks all doing different positions. One of them is kind of like the greeter out front, and they're meeting people, they're finding out what their chief complaint is, what we do, what they're here for, and how we can help them. One of them might be getting insurance information or updating their address and contact information, all of that stuff. As I said, one of them in the back with us that's doing all the phone calls and the paging kind of keeps track of everything that's going on. We have lab personnel that are in our emergency department. So we may have phlebotomists, which are usually on-the-job training that draw the blood. And we have some medical technologists, which is a 4-year degree. And then usually they do a clinical rotation where they are, med techs is their name, and they will actually be doing all of the lab tests. They may work in blood bank or hematology or a variety of different areas. And sometimes they come over and draw our blood. Sometimes they are just the ones in the lab actually doing the tests. CT techs, radiology techs. So we will have a variety of people depending on what the patients need that will come over and either do some of those testing right in their emergency department or take them to their radiology area or their CT area. Caseworkers and social workers. We have some nurses that are caseworkers that help us with figuring out complex situations. It could be, where is this patient safe to go home to, or it could be helping us to locate family, looking at what resources this patient has, maybe looking at their insurance information, how can we get their medications that they need covered, those kind of things. We have social workers that will help us with, sometimes it's end of life decisions, sometimes it's transferring a patient to places, so a variety of different things. Security. That's probably one area that you may not have thought of that we need in the emergency department. And security is definitely needed in the emergency department, especially as we deal with more and more violent crimes or drug-related issues. We have more and more need for security. And they literally, their security office is right across the hall from our entrance to our emergency department, and we utilize them a lot. Clergy. There's a lot of things that happen in the emergency department that we need clergy for. Sometimes it's for our own staff to help deal, and other times it's to be there and make sure that there's a contact person to be with family and friends. And then environmental services. We couldn't do what we do every day without these people. They're the ones that help us keep our emergency department clean, especially now during COVID. There's a lot more cleaning, but we also have a lot of other diseases that need special cleaning to all of our rooms. And so they're a vital part of what we do. So you can see it's a whole team in the emergency department that helps us. And they all have very different backgrounds, very different educational backgrounds, from a physician that has many years of schooling to a nurse that could have gone through a 2-year nursing program or a 4-year bachelor's program. Physician assistant usually has a bachelor's degree and then goes on into a physician assistant program. Nurse practitioners are nurses first, and then they go back into a nurse practitioner program. We have paramedics and EMTs, and we have EMTs that our EMTs are trained here, but they have to have an EMT license. So they've already gone through either a basic or intermediate training programs. Any questions on all of that?
Nope.
All right. So what do we do in the emergency department? When we have patients come in, it can't be like when you're standing in line at the bakery and they say, take a number and we'll help you, because sometimes there's a lot of patients here at once. We have to figure out who needs us the most and how can we help them. So we do what we call triage, and triage is it means to sort patients basically. So every patient that comes in is triaged by an ER nurse, and they immediately triage them to determine, are they emergent, urgent, or non-emergent? So emergent patients are our highest priorities. Those are those patients that need to be seen immediately and taken care of immediately. The urgent ones, they're high priority, but they may not need us immediately. And then non-urgent are the lower priority. And we're going to talk about some different types of patients that we might be seeing and what that looks like. Some of our emergent patients come through our ambulance bay. They come by ambulance, which is how we would hope that a lot of emergencies come, but some of them don't. They walk through our front door with very serious injuries or illnesses. And likewise, there's some non-emergent things that come by ambulance. So again, it's the triaging of who gets to be seen first or who needs to be seen first, and what do we do with them. And then after we triage, we assess that patient and intervene. And there's a primary survey and a secondary survey. So your primary survey means you kind of take a look at them and you look at all the life-altering issues they may have. So I know you've already gone through CPR, so it's your airway, breathing, circulation, all those important things, and determine, is there something we need to do immediately for this patient, or can we go on to some of the other things in the secondary survey. So now we're going to talk about the different types of patients that we see. And these are a whole variety of different complaints that we might be seeing in a patient. And this is where we're going to, this is going to also be interactive. And I'm going to talk with you about if a patient presents and they say this, you're the triage nurse, would you determine that they're emergent or non-emergent? You know, are they emergent? Do they have emergent needs? Do they have urgent or non-urgent? Okay, so chest pain. What do you think of somebody that tells you they have chest pain? Anybody? What do you think? Is that an emergency? You guys are awful quiet today. What do you think? A patient comes in and says that they have chest pain, or you're with somebody at home, a parent, grandparent, and they say they have chest pain. Is that something that needs to go to the ER immediately, or can it wait till tomorrow, or wait a couple hours?
Wait.
You think that can wait?
Yes.
No, chest pain usually can't wait. If someone has pain in their chest, we're worried about something cardiac related or something going on with their heart, and we want them to come in right away. So chest pain is going to be a true emergency. These patients come into the department very quickly. We have lots of guidelines of what we follow and lots of metrics or goals that we want to meet. So for someone with a chest pain, we want to be able to do an EKG within 10 minutes of them walking through our door, because we want to make sure, are they having a heart attack? Are they not? What else is going on? Okay, so that would be an emergent. Difficulty breathing also would be the same. We're concerned that we'd ask a few more questions maybe, like, when did your difficulty breathing started? Did it start when you were outside running a marathon, or did it start when you were sitting in your chair? What does it feel like? Are you able to breathe at all? What do they look like? You know, are their lips blue? Are their nail beds blue? Do they need immediate intervention? But usually someone with difficulty breathing is, again, considered emergent. Stroke, we're going to talk a little bit about stroke as we go along, but anyone with stroke symptoms, again, needs to be classified as emergent and needs to come into the back immediately. All right, next one, abdominal pain. Give me some ideas of what someone with abdominal pain might be going through. What causes your belly to hurt?
They could have like eaten too much, or their appendix could have burst if it's like really serious.
Okay, good. Those are both very good examples. So with abdominal pain, we're going to ask more questions. How long has it been hurting? How bad is the pain? Are they, vomiting? Are they able to keep any food down? Those kind of questions, and determine when they need to be seen. So this is probably an urgent patient. They need to be seen soon. But if somebody presents ahead of them with chest pain, we're going to take the chest pain patient first before we are the abdominal pain. How many of you have ever been in an emergency department? Any of you?
Tour, but I haven't been a patient, thankfully.
You haven't been a patient. You've toured it, okay. So when you come in, again, a lot of times people think, all right, I'm here, you should take care of me right away, and there's this triage process that we need to do to determine how serious it is. So moving on to the next patient, broken arm. If you broke your arm, would you want us to consider it emergent or urgent or non-urgent?
I would say that it wouldn't be super urgent unless there's like you split it and you could see like the bone and it's like really bad. But if it's just like a small fracture and there's no blood or anything, I feel like that could wait a while.
Okay. We'd ask more questions, like how did you break it or what happened? Because we want to know if it was a traumatic injury, meaning was there trauma? Did you fall off your bike? Did somebody beat you up? Did you just trip and fall on the sidewalk? Some of those information, because maybe the broken arm is all you're complaining of, but there might be a lot of other injuries as well if it was like a car crash. So we'd ask more questions, but you're right. In general, a broken arm, depending on the patient's age, we'd probably wait. It may be urgent, but it's not definitely a highest priority emergency. The bone sticking out, you're right, that changes things a little bit. Nosebleed. We see a lot of people with nosebleeds, and especially more so in the winter when it's very dry, and we'll see that. For the most part, sometimes people come in and they've lost a lot of blood with a nosebleed. So those are things that we have to, again, ask more questions and individualize. If they're, especially if they take a medication that thins their blood, they could be losing a lot of blood and they may need to come be seen very quickly. Other times, it's a nosebleed that happens to them quite often. It's just that they couldn't get it to stop this time and they may be able to wait a little bit. Sore throat. What would you consider that?
Not really like a emergency. I feel like that's something that you could wait and see.
Right. A lot of times people think that the emergency department sees critical patients all the time. And we do see a lot of critical patients, but we also see people that could have probably gone to either a walk-in clinic or their family doctor, or maybe didn't even need to be seen at all. But we need to treat every patient. So some of these people might wait quite a bit of time, because you're right, a sore throat may not be as high a priority. Just like an earache. And we may not think of it as bad, but if it's your baby and they're screaming all night long about their ear hurting, definitely in the emergency room is the only place that's open. We see a lot of parents that come in during that time. And again, we'd want to ask more information. Does the child have a high fever? What else is going on? All those kind of things. Vomiting, the last thing on this list. What are they vomiting from? This time of the year, when it gets really hot out, we'll see people with dehydration related to overexposure to the heat, and they maybe haven't been drinking and they're going to start vomiting. Or it could be related to something going on in their GI, something infectious kind of thing going on. We do see vomiting as a complaint with COVID as well. Vomiting, abdominal pain, that kind of stuff. I know yesterday you talked about COVID with the public health nurses. So asking more questions. Do they have abdominal pain with the vomiting? When did it start? All of those kind of things. All right, how about an insect bite? Do we consider that a high priority?
I would say depending on like what the bite is, if it shows like signs of being really serious and like poisonous, then you want to get it treated, because like the venom could like go to the heart or something like that.
Good, very good. That's exactly right. That's what I was getting at. Sometimes people will come in and say they've got bites all over, but other times it could be, maybe it's a bee sting. And it's a bee sting and they're allergic to bees. That is a very high priority. That is an emergent patient that needs immediate care. Okay, good answer. Falls, we see, that is our #1 type of trauma that we see is a fall. And it could be ground level fall, meaning you fall just from standing, or it could be a fall off the roof, fall out of a tree, any of those type of things. Slip and fall on the ice. So we ask a lot of questions. What height did you fall from? We consider certain things trauma. So if it's more than twice your height, we consider that a traumatic fall. So you fall from a roof, that's going to get you moved up the ranks as very emergent. Car accident. There's some car accidents that are obviously very life-threatening, and there are others that are, the injuries may not be very significant at all. They're obviously significant to that person, but maybe not need to be treated right away. And some people from a car accident come in through by ambulance. Others will come in through our front door. They'll come maybe a couple hours or a couple days later when they're realizing that it's still really bothering them. So again, a lot more questions that we'll ask, and to determine, is this a trauma patient? Does it need trauma priority, or what else is going on? Ingestion. So with ingestion, that's the term we use when we talk about somebody that swallowed or took something that is dangerous to them. So it could be an ingestion, an intentional ingestion, such as an overdose, which unfortunately we see a lot of, or it could be an accidental ingestion, such as a child that got into some cleaning supplies or got into some pills. Maybe they're vitamins, they're gummy vitamins that are so good and now they ate half the bottle, which can be very dangerous. So finding out what they ingested, what time they ingested it, and where, what the drug was, so we can identify what's next. Foreign object, we see a lot of these. There can be foreign objects in a lot of different places. It could mean that you stepped on something and you have maybe you have a nail impaled in your foot. That hurts a lot, might not be the highest priority and need to be emergent, but it definitely needs to be seen. Definitely could be an urgent thing. Or it could be a knife that's impaled somewhere in your body. That's obviously a much higher priority and definitely needs to be seen right away. Visual problems. So are there any problems with seeing in one or both eyes? Those are signs and symptoms of a potential stroke. So we would kind of go down that stroke pathway, or it could be that they have pink eye, or so they have pain in their eye, or maybe they have pain because they have a foreign object or a foreign body in their eye, such as they have got a piece of glass in there, or a stick or something like that. So we ask a lot more questions about that. Constipation. Does that sound like a medical emergency? Sometimes it is. Sometimes, depending on, again, asking more questions. Other times this is a patient that we do definitely need to see and take care of, but they may be on the non-urgent side. Leg pain. So often when somebody comes in, they give a 1 or 2 word description. When we say, what are you here to be seen for? And they'll say leg pain. So we ask, again, a lot more questions. Is it leg pain because you got hurt, you fell, you maybe overexerted yourself, or maybe is it leg pain, it just came on suddenly, and then maybe we're worried more about a blood clot. They say, I was just on a long car ride and now my calf really hurts bad and I can't step on my foot. Okay, then we're concerned more about a blood clot. So asking a little more questions, that's all part of that triage process. And then lastly, I put on here cough, because I think during this time of COVID, we're very afraid of a cough. Somebody has a cough, we're gonna go, we have different thinking than we did even 6 months ago because of what's going on in the world. So somebody with a cough, we definitely, everybody has their mask on, has their face protected, and we have to be thinking, what other kind of history do you have? Where have you traveled to? Have you been exposed to anybody with COVID? All of those kind of things. Any questions about the complaint?
Nope.
All right. So, a day in the life of the ER staff. Here I wanted to run through some of the emotions that people feel. And I can tell you, after many years of working in the emergency department, there's a certain kind of excitement that goes along with it. Anyone that works here, we say it gets in your blood, and we love what we do. There's that adrenaline rush of never knowing what's going to walk through the door. So it could be that right now I'm caring for somebody that has a nosebleed, and 5 minutes from now I'm going to be caring for somebody that was just involved in this crash like you see in the picture. So you never know what's going to happen. That can also be very anxiety producing, because you're anxious, like, what's going to happen? What am I going to see today? There's times that can be scary. Scary because you're not sure what's going to happen with this patient. You're worried about your own safety. It could be your own safety related to whatever disease that patient has. Is it contagious? Or it could be scary from the point of, you know, this was a shooting, or it was gang-related violence, and are we safe in the emergency department? Those kind of things. Sad, it can be very sad. Unfortunately, we deal with all real life things, and we see a lot of death. We see a lot of things that really tug at your heartstrings. but we also know that we make a difference in their lives. And sometimes that is really what gets you through the day, when you know you've made a difference in someone's life. It can be very happy. There's a lot of times where people come in, they're very scared because they don't know what's going on with them. They have some illness that they're not sure of, or they were in an accident and they're scared, and we can provide them with comfort and a diagnosis that to them was less scary than when they initially came in. So there's a lot of very happy times too in the ER. I already talked about some of the dangerous stuff. As I said, we deal with a lot of very violent patients, and we deal with things that, oh, I may lose you on my picture here. I see my cell phone's dying, sorry. We also deal with things that are, yeah, as I said, dangerous to us. Other words, when I asked other staff about how would they describe their feelings, sometimes they feel just very helpful. You're able to assist someone and they were struggling at home, and now you were able to provide them with maybe a walker or some home resources that they didn't have before. And it's very rewarding. Seeing the smile on somebody's face or just knowing that you were able to comfort them or help them is very rewarding. So there's a whole broad range of feelings that you go through on a daily basis. You feel all of these. All right, I want to show you a brief little video here.
Hi, I'm Will Cristobal, and I'm an emergency room nurse. A typical day in the ER is not really that typical because it's always different. Everything's different every day. I mean, granted, you'll see similar scenarios, but each person.
Not sure what it is.
So you have.
Can you hear that?
Non-critical to the extreme critical. I mean, for example, I'll get a guy with a laceration. I will clean it up, and the doctor will stitch it up. Nice. Or someone will come in with abdominal pain. I'll put an IV line in them, get their blood work, start IV fluids, and give them pain medication to get them comfortable. Or a guy will come in with complete cardiac arrest. The whole team is inside the resuscitation room, and we're pumping, we're pushing medications, we're putting IV lines, and shocking the patient, seeing if we'll bring them back to life. Sometimes it's successful, sometimes it's not. Nursing school is really cool. I actually enjoyed it a lot. At first, it's very nerve-wracking because you're interacting with patients, you're touching patients. I was one of the very few men in the classroom, but I mean, it was my fault. The perception in nursing is typical. You think a nurse is a female. When there's 10% of the profession are male. There's times when I've actually come in, saw my patient, hi doctor, how are you? I'm like, no, I'm your nurse. And then when the female doctor comes in, it's kind of like, this is your doctor. I'm your nurse. So I mean, it's just really interesting, like the dynamics with patients sometimes, and that I actually have to correct them. And they always go, hey, you never thought about going to medical school? I'm like, no. I wanted to be a nurse. I enjoy nursing. I enjoy being at the bedside and taking care of my patients. My career path after high school, I actually thought about doing physical therapy. I actually wanted to be in the health field. I didn't want to be a doctor because I knew it was going to take so much time. So I thought about physical therapy. So when I was in college, I ended up taking classes geared towards physical therapy and decided I don't really like this stuff. But I still wanted to stay in healthcare. After college, I ended up just trying to find odd jobs, things to do. I worked for health insurance. I worked for HR, trying to fit my personality. At any rate, I thought that was boring. And so one day, my wife's uncle, was like, why don't you do nursing? He was a nurse. And so I said, let me look into it. I volunteered at this hospital, observed the nurses and everything like that, and doctors, and I was actually cool kid. I'll do this. And so I applied to nursing school, and luckily I got it. There you go. When it's really, really busy, you may have a critical patient in one room, and then a person that's not so you to, discharge a patient in the other room. So at any given time, I can have 4 patients, but all 4 patients can want something all at the same time. You have to really like people, because you have to deal with a lot of personalities. If you enjoy interacting with people, helping people, make people laugh, make people smile, I mean, this is a great career for you. I mean, if you love math, if you love sciences, I mean, this is a great career to get into. You use a lot of that stuff. I mean, you have to. You have to think about disease processes, and so you have to think about your anatomy and biology and how the cells work and whatnot. The advice I'd give for high school students: volunteer. Go to a local hospital and volunteer. It will give you a chance, to know whether or not you want to do this, because you'll be in direct contact with nurses. You'll be in direct contact with patients. You'll be in direct contact with doctors, and so you get an overall chance to see exactly what this is about.
All right. Oh. Sorry about that. I was moving on to the next one. So what do you think about that? It kind of, what I wanted to do with that video is kind of show you what we were talking about, the wide array of you maybe caring for one patient, helping to suture up a laceration on their finger, and then the next minute you're doing CPR. So a lot of different things happening all at once. This slide, I want to talk about expert care for all ages. When you work in the emergency department, you don't specialize in any one thing or any one type of patient or age. You may deal with babies, newborns, all the way up to, I've dealt with people that are well over 100 years old. So you kind of have to be an expert in all things. You learn about each different stage. Caring for a 2-month-old is very different than caring for a 6-year-old, then a teenager, and then somebody that's 80. They all have very different needs. When I look at this picture, the baby picture, what do you think when you look at this picture? What are your feelings? Like, does it make you feel sad, happy, concerned?
Sad and concerned.
Yeah. This child doesn't look happy, do they? Now, when I look at this picture, I see, if that's my first glance, I see a baby that's awake, they're alert, their color looks good, they're showing emotion, they're crying. Those are all very positive signs to me in the emergency department. When I see a child that doesn't open their eyes, they're very listless, or they don't move, that's a baby that concerns me a lot. So believe it or not that I want to see babies cry, but a crying baby means that they at least have an open airway and they're at least healthy enough to cry. So we take that all into consideration. But yeah, it's sad, isn't it? Looking at a child that is just not happy. All right, we're going to talk about some trauma. I'm going to throw some pictures in here for any of you that might be somewhat interested in radiology, being a radiology tech, being a radiologist itself, the physician, or working in a CT scanner or MRI, any of those kind of things. So I want to show you some pictures. This is a picture of somebody's skull. And the arrow right here shows a crack in that skull. And we call that a linear skull fracture. So there's 2 types of skull fractures. One where there's just a crack, and one where there's actually, it's called a depressed skull fracture. And that'll be my next picture. So with this type of fracture, often when I explain it to people, I think of when you open up an egg carton and you see an egg that has a little crack in it, you might be thinking, oh, is that egg going to be any good, or is it damaged? Is it open all the way through? That's kind of a linear skull fracture. You might not see it if somebody has a lot of hair. You're probably not going to see anything on their skull that's going to tell you that there's a skull fracture. This is going to be a radiology film that's going to show that. A linear skull fracture hurts. Your skull is very, very thick. In adults, women actually have thicker skulls on the average than males do. But it takes a lot to break a skull. So if you see this picture, you have to think, well, what's going on underneath it? What's going on with the brain? If they got hit that hard, whether they fell and hit their head or somebody hit them, what else might be going on? But that's a linear skull fracture. The next one is a depressed skull fracture. So just a little bit different view of the picture of the head, but this I thought showed it very well. You see that piece of bone that's pressed in. The brain should be on the inside. So if you have a chunk of skull that's pressed in, that needs to come out of there. So that patient needs to go to surgery. Again, going back to our analogy of the carton of eggs, if you open your egg carton and you see that the yolk is coming out or the egg white is coming out, that's a depressed skull fracture. That's something that you need to do something immediately about. Then I'm going to look at different types of bleeding. And some very big words here. This is the epidural hematoma. Oh, it looks like the A didn't appear on the screen. When you look at a head scan, the two sides should be symmetrical. So as you look down, everything you see on the left side should be on the right side. Well, in this case, can you see my arrow moving?
Yeah.
Okay. So as the arrow moves right here, this is all blood built up in there. So we know that this person has what we call an epidural hematoma, and it's blood on top of the dura, so it's above it. And usually this blood comes from an artery, meaning it's fast bleeding, very fast bleeding, but it always has this kind of shape. If you notice, this line right here should be the center of your brain, and it should be straight down. And you notice it's not. And these are ventricles in your brain, and there should be two of them. And this one, you can see it just a little bit here. So that means all this pressure from this blood clot is pushing over this way, and we call it a shift. It's shifting the brain. That's a lot of pressure. If you think about inside your skull, there's no room for it to expand, for your brain to expand. So if you've got bleeding in here, where's that brain going to go? It's not like if you sprain your ankle and it can swell and swell and swell, because this is surrounded by bone. It doesn't give. Okay? So that's an epidural hematoma. This one is a subdural, sub meaning below the dura. These are usually long and skinny. This is a huge one though, but this is long and skinny compared to the previous one that was more circular shaped. Okay, so this is a subdural hematoma. Underneath the dura, meaning it's right tight against the brain itself. And again, this line should be straight and it's not. These are the ventricles and they're pushed together to form what looks like one big ventricle here. So that's a lot of blood in there. They need to take out this bone flap and relieve that pressure. This is, it's called a GSW, or we as we refer to it, but it's a gunshot wound. So this is a gunshot wound to the head. And you notice these are the eyes. This should be the nose in here. And this head is turned a little bit to the side, but as you can see, the white is the bone. So white should be all the way around. Here the bone is interrupted, and here there's obvious disruption of the brain itself. All right, so we're going to talk about a whole variety of things. What is the #1 drug that is abused in the United States?
Alcohol?
Yes, yeah, alcohol. By far, it's the #1, and especially in Wisconsin, we have a very high alcohol abuse rate, but it is the #1 abused drug. And we see a lot of patients in the emergency department that are here with a variety of things. It could be an injury, it could be an illness, but alcohol has definitely played a role in that. So just a little bit of information and kind of maybe pique your interest for one of the presentations for next week on injury prevention and the roles of alcohol and drugs. All right, I'm going to jump into stroke care. As I said before, that is my main job. Is I am the stroke coordinator for our 10 hospitals, and we see a lot of stroke patients. So I want to just talk about a little bit about the basics and a little bit about what you can do in your community to share some of this information. So what causes a stroke? What are the signs and symptoms of a stroke? And what do you do if someone is having a stroke? So we're going to cover each one of those as we go along. So stroke is any sudden neurological deficit caused by an impairment in perfusion to the brain. So that's a really big definition. What that means is suddenly your brain isn't getting the blood flow that it needs, and your brain needs constant blood flow. Your brain uses approximately 20% of the body's blood flow. So if you think of the size of your brain in comparison to the rest of your body, and 20% of it is being used there. So any sudden deficit caused by an impairment, meaning that blood can't get through, that's a stroke. The third statement on their brain does not store glucose. So why that's important is we need glucose to make our body work. You may have at times when you get really hungry or your blood sugar gets low, you just can't focus as much, you can't function as well. And the brain doesn't store that. So we need to make sure that we're getting adequate glucose to the brain to help it function. And approximately 2 million neurons die per minute in a stroke. So if you think about it, when a stroke happens, it's almost 2 million neurons die every minute. Hard to believe that we have that many neurons in our body. So that's why stroke is truly an emergency. It truly means if someone is having a stroke, you need to call 911 and get them to an emergency department as quickly as possible. Just since we started doing this presentation, which has been about 45 minutes, think of how many million neurons. So you've lost, if you were having a stroke, and if it started when I started talking, you would have lost 90 million neurons in that amount of time. So, and we don't get those back. So stroke is very time sensitive. This is a diagram of the brain itself. So you have, your brain's divided into the frontal lobe, parietal lobe, temporal lobe, and occipital lobe. And each of those lobes has different functions. And knowing the anatomy of the brain helps us to determine where the insult to the brain might be. I'm going to show you a very quick YouTube video, and then we're going to talk about the signs and symptoms of a stroke.
What is my grandma's having? I think I better ask that. minute after that, more brain cells die. My heroes acted quickly, and so they all had hope. Precious time and emergency care. You can see the stroke. You can see the stroke. Call fast for any kind of stroke. What you gotta do? Call fast, call 911. One you love is depending on you, someone. Depending on you, someone. Depending on you, someone. Depending on you, someone. Depending on you, someone.
All right. So your assignment for today is, can you share that story with somebody? Can you talk about stroke and the signs and symptoms? 60% of the time when a patient has a stroke, it's not them that realizes there's a problem, it's somebody else. And it can be their child, their grandchild, their neighbor, somebody just watching them. It could be at on a bus that you see this happen. So being aware and raising awareness is very important to early treatment because, as I said, you lose 2 million brain cells per minute. So the sooner we can identify somebody having a stroke, the better. What I have listed on the screen is the bottom four letters are the same as what they talked about in the video: FAST, face, arm, speech. T can also, besides time to call 911, it can stand for terrible headache, because there are two types of strokes. One of them is a hemorrhagic stroke or bleeding in the brain, and that is very painful, so sudden onset of a headache. The first two letters, balance and eyes, that is strokes that are not as common, but we do see them. So sudden onset of loss of balance, meaning you're dizzy, significantly dizzy, and it comes on really suddenly. That could be a stroke in the back part of your brain. And eyes, it can be sudden loss of vision in one or both eyes. So those are the signs and symptoms. The different types of strokes, as I said, some big words: ischemic stroke or hemorrhagic stroke. 85% of the strokes we see are ischemic, and they either come from an embolus, which is a clot that comes from somewhere else in the body. Usually it comes from either the heart or it comes from the carotid arteries in your neck, and it's a piece of plaque. Those are the most common areas. A piece of plaque that breaks off and it goes up into the brain and causes a stroke. Or it can be a thrombus, and that would be a clot that is slowly forming. It's kind of like sediment building up in your vessels until it gets to the point that nothing goes through. And then hemorrhagic strokes, I've listed two types of hemorrhagic strokes. There's a subarachnoid hemorrhage, which is usually caused by an aneurysm or a valve malformation in your brain that has ruptured, or it could be an ICH with an intracerebral hemorrhage or intracranial hemorrhage that is caused by usually hypertension or high blood pressure that is untreated, and eventually those vessels just get kind of weak. And this, I want to show you this cool picture. The picture on your left, these are in the brain. So when somebody has a stroke, if there is a blood clot in the brain that we can go after, they'll put a catheter in through the groin, through your femoral artery, and go all the way up to the brain with this little device that grabs onto that clot and pulls it out. So in the first picture right here, they're trying to put dye in. That's the black stuff, the dye in. And as you can see, half of the vessel kind of looks like a tree over here. The other half, the other branch, there's nothing. So there's a clot sitting right here. So this is the before picture, and this is after. So as soon as they've pulled that clot out, now the blood is flowing again to the brain. So pretty amazing treatment options that we have. So if you're thinking of a job in healthcare or in the emergency room, what kind of classes can prepare you for life in the ER? Definitely, as we saw in the video, science classes can make a big difference, as well as math. So we're going to talk a little bit about math. I've got a math question coming up for you. This is a real life scenario of some of the math we do every day. So here's your story. Doctor orders vancomycin, 500 milligrams. So vancomycin is an antibiotic, 500 milligrams to infuse at 5 milligrams per kilogram per hour. The patient weighs 98 pounds. You are supplied with 500 milligrams per 100 milliliter bag. How many milliliters per hour will you administer? Anyone have any ideas how you would start to tackle this math problem? Are you all thinking or just not quite sure? All right, the very first thing that you need to do is think about how much this patient weighs. So 98 pounds. Anybody know how to convert pounds to kilograms? Jordan, any guesses?
No, I'm not sure.
Okay. So if you have somebody that weighs 98 pounds, if you divide by 2.2, you will get how many kilograms? So if we divide 98 by 2.2, we get 44.5 kilograms. So that's how much the patient weighs. So you can see my highlighter or my arrow on here. We have 5 milligrams for every kilogram. So that's where you need your math skills there. You need to multiply 5 milligrams times 44.5. That would give us 222.5. Then, so we know how many milligrams per hour, but we need to find out how many milligrams per milliliter we need to do, or milliliters per hour. So you set up your math equation and you look at, there's 500 milligrams per 1 milliliter. And we know that we have 225 milligrams per milliliter that we need. And so you do your multiplication and division, and you come out with an answer of 44.5 milliliters per hour. So math is very important in everything that we do. Sometimes people think all of that algebra, trigonometry, all of those kind of things are something you need to just do in school, or you only need to do it if you're going into that field. But math is very important in healthcare. All right, we're going to skip that next question. And we are to the end. Any questions that you have, or any thoughts, or do you know anyone that works in an emergency department?
I just wanted to say thank you so much for the presentation.
Yeah, thank you. It was really good and thorough, and I learned a lot of new things that I never learned or thought of before.
Great. Are there any jobs in the ER that you'd be interested in?
I'm not sure. I gotta look at them.
In healthcare, like in general, I'm kind of interested in being a nurse. My mom is a nurse, and I know a little bit about it, but I'm still researching.
Okay. What kind of a nurse is your mom?
She's an RN.
Okay.
Registered nurse.
Does she work in a hospital?
Yeah.
There is something about ER nursing, right, Mary Jean, that gets in your blood, and you just can't. It is not something that I thought of. I knew I always wanted to be a nurse. ER was not an area that I thought would be something I was interested in. I love neuro, and I did a lot of that. But once I came to the emergency department, kind of found your niche and realized how exciting it is.
Actually, my story is much different. I knew I wanted to be an emergency department nurse right away.
Did you?
Yeah, I will have to let you know my story then. I was actually a florist before I was a nurse. And I worked for my parents, and so I took my kids with me to work every day. And we had like a little nursery. My children were very, very small at the time. And my daughter was only like 6 months old, and she choked on some medicine and she quit breathing. And it scared me so bad that I had no idea what to do. And I did not know CPR at the time or anything. And so I could not even dial the number on the telephone because I was so scared. And so anyway, my dad knew CPR, and so he gave her mouth to mouth. And so the next CPR class that was offered, and she's fine, by the way, everything worked out just fine. But the next CPR class that was offered, I was going to be in it, and so was my husband. And so we did, and then that was how they were recruiting, because we lived in a very rural area of Wisconsin. They were recruiting people to join the ambulance through CPR classes. And so they asked me if I wanted to take the EMT class. And so I did, and I loved it. I absolutely loved being on the ambulance and helping people in their time of need. And so when I went to nursing school, I knew that I wanted to be in the emergency department. So, and I worked in the emergency department for 28 years altogether. And now I'm educating nurses. So,
It's fascinating to listen to healthcare workers and hear their stories of why they chose the profession that they did.
Right, exactly.
And usually it's because it's similar to yours. They were impacted by somebody else and they knew they wanted to help.
Exactly. So.
All right, any other questions?
All right, and tomorrow I'm excited to let everyone know that we are going to visit the emergency department where I was working before I went into nursing education. So anyway, I did get permission, as long as they are not busy in the emergency department tomorrow. We will actually take a tour and go to the pediatric resuscitation room and see some of the equipment and everything there. So, and talk with some of the nurses, and one of the physicians is going to talk with us. And so that's where we will join tomorrow. So please join in.
That's exciting.
That is exciting. I didn't know if we were going to be able to do that during COVID, but yeah.
And I'm hoping on Thursday, our plan is to be with the medevac helicopter crew.
Excellent.
So, and with a backup, hopefully, of the ground crew in case the flight crew is out, but that's what I'm working on.
All right, sounds good.
All right, have a good day.
Thanks everyone for joining. Well,
thank you.
Yeah, and if you want to listen to Lisa's presentation again, it'll be posted to the YouTube channel later today.
Sounds good.
All
Bye.
right. Thanks, bye-bye.